strictly quickly onto the next session, which is really about AI transforming healthcare, real-world use cases, and emerging opportunities. And I'm going to ask each of the panelists to quickly introduce themselves. So, George, can we start with you, please?
Sure. So, hi everyone. George Margelis. I'm classified as the grumpy old doctor from down under. Let me put that in context. I come from Australia. It's a long way away. Australia has the world's best healthcare system. I'm not saying that. The Commonwealth Fund, the WHO and OECD reports all put us up there as the best healthcare system in the world, because we have both high quality, very safe, very effective and very efficient care. We have the longest longevity of the English-speaking world. We have probably up at amongst the top 3 longevity in the world. And as far as digital health goes, a recent report looked at national digital health strategies, and Australia and Estonia came in equal first. Now, we heard Ain speak earlier about the Estonian digital health strategy. Our digital health strategy scales out to 170 times the size of Estonia, so we probably have the greatest digital health strategy in that respect. We also have 100% computerisation of primary care, 100% computerisation of our public hospital systems, national digital health record, a national telemedicine service. As far as standards go, FHIR, Fast Healthcare Interoperability Resources, came from Australia. My good friend Graham Greaves invented it. We have the greatest use of standards. So we have a really, really good healthcare standard, yet we're still very grumpy. Why are we grumpy? Well, Australia is a country of migrants. 98% of the country has come from overseas. Some of them came in shackles from the UK 200 years ago, but the bulk of them have come by choice, and they've come there to get a better life. So we constantly look at how we improve what's happening in our country. We actually often quote the original Robert Fitzgerald Kennedy. We not look at things as they are and ask why, but we look at the dream of things that could be and ask why not. And that's why Australia has progressed so well in that space. So I'm grumpy because we can do better, but we are doing really well. But the beauty of these events is that we actually get to share that skills and knowledge across the world. So it's really exciting to be part of the ECH Alliance. We're not part of Europe, but the ECH Alliance is a global collective now, and we're really excited to be working with this space.
Great. Maria.
Thank you. My name is Maria Cabrera. I am professor of biomedical engineering at Universidad Politécnica de Madrid. I am also treasurer of the International Federation of Biology and Medical Society, and then also Secretary General of the Active Age organization. I'm here because I am the coordinator of one European initiative that is called Brain Teaser, where we are using artificial intelligence model in order to support the treatment of patients suffering for different neurological conditions.
I'm here for the 3rd time, I guess, because of the population I represent.
Yes.
1/6 of the planet. Thank you.
Okay, so our first question to talk about is, what do we mean by AI as opposed to machine learning? So who's going to start us off?
Okay, I can, from the academic point of view, let's say, I have to say that artificial intelligence is more like the umbrella concept, where it's referred to systems that try to mimic the behavior of the human or the intelligence of the human, while it's encompass different techniques like natural language processing, expert systems, or machine learning. So with machine learning, we mainly refer to algorithms that learn from data. So it's more in the case of healthcare, that is the topic that we are dealing here. This is more used to predict several problems like disease progression or even treatment outcomes. So this is more or less.
Yeah, look, the analogy I would use is a car versus how a car works. So a car is artificial intelligence. The physics between how an internal combustion engine works and how an alternator works is physics. That's a machine learning. That's the nuts and bolts behind it. And again, we looked at machine learning. There's 1,000 different models of how machine learning can work. What it produces as a product is like a car. The product is what I, as a doctor, would use. I don't really care how the algorithm's calculated. I want to know it's reliable, but I want to make sure the tool that I use provides me with safe, high-quality, effective information so I can make good clinical decisions.
So I know that he was a lawyer, and this is the, kind of, I would say, quizzing us on the basics. So I would have definitely answered that. So artificial intelligence gets at the lowest level, and as you know that as the artificial intelligence passes through different layers, it learns by itself. So the next layer is the machine learning, then is the neural network. So I wouldn't go one step beyond on that. I would actually want to then maybe, as a very good student, I would confuse my teachers by asking a tougher question, which I didn't even know the answer for. So I'm going to put it this way that, earlier it has been deterministic framework-based AI. So you trained an AI, and you ask any question based on the framework, it would give you an answer. The moment you asked outside that deterministic framework, it would hallucinate. But what has happened is, eventually, as it got trained on data, it started becoming more intelligent. So it has become non-deterministic. So it is learning and becoming intelligent, and machine learning is enabling that thing, And I think it will advance further when it doesn't require. That's why I gave the example in the morning of conversational AI. Then you have reasoners, autonomous, innovative, and organizational AI. The last level with the organizational AI.
Okay, so can we talk a little bit about real-world use cases for AI that each of you have seen and that you think could be coming down the line, if you like?
Cool. So I think, first of all, one of the few good things about getting old is you get to see cycles. So cycles of AI have been going on for quite a while. Back in the 1970s, there were cycles of AI. And the belief that clinicians don't use AI is false. When I was a junior medical officer, I carried a little yellow book in my pocket called the Oxford Handbook of Medicine, and that was our source of information. The most innovative thing about that book, it had a plastic cover so we could wipe the blood off at the end of the day. It was a really quite useful thing. Yeah, we have to think about those models. Now, going forward, one of the biggest limitations we've had with AI in Australia is that the data has to be held onshore. So we had to wait until AWS, Microsoft, Google put their cloud services in Australia. But then we started seeing some really innovative uses. Most innovative use I've seen is on the back end. So yeah, there's a lot of clinical uses, and we can discuss those, but a very simple procedure which looked at complaints management and took complaints management from an 8-week process to an 8-minute process, so that if someone placed a complaint, the right people were notified, the risk register was updated, the documents that were required were sent to the relevant risk manager, and the people who made the complaint received feedback within 24 hours, led to a significant drop in poor outcomes. We didn't have as many law cases because the problems were solved. So the AI solved all that problem in the back end, which previously would have required 8 people to shuffle a piece of paper or send or forward an email. Clinically, where we've seen some really great work in Australia, is taking what's always been digital. So retinal images have been captured digitally in Australia for 35, 40 years that I've been a clinician. We now take those retinal images and using AI, analyse them, not just to look for diabetic retinopathies or for those classical eye diseases, but to also predict neurological and cardiovascular disease. So now we can use that data, which has been captured when you go for your eye test at the age of 40 because you can no longer read your newspaper, and give you a predictive algorithm around, okay, here is your risk of neurological disease, cardiovascular disease, and other diseases down the track. So those sort of things are great.
Yeah.
If I can comment on the brain teaser itself, where we are using patient data, basically lifestyle and clinical data, plus environmental data. We are using this data to create models that can predict the disease progression in the case of patients with amyotrophic lateral sclerosis. So our use case in this aspect is patients suffering for this disease and also patients with multiple sclerosis, where we collect this data also to detect further episodes that these patients suffer. So we have created different tools for the clinicians to help them in order to decide on the continuous treatment of the patients, or even to decide on what is the next stage and the level of the progression of the disease. Because in particular, in the case of amyotrophic lateral sclerosis, let's say that the disease, the patient died at the end, so it has a very short, let's say, development of the disease. So for the medical professionals and as well as for the patients, it's very important to know when the next stage is coming and if we can improve their quality of life before this happens. This is one of the cases that we can see from this project, but there are many other use cases in terms of the hospital's resource allocations in the hospital. You mentioned also let's say back end, more in the front end, let's say, clinical use, also in the medical imaging field. So when we use different technologies to extract information from medical imaging to provide a new knowledge on the patient disease.
So it's a very broad topic, and I'm going to stick to some of the areas. So last week, leading hospital in southern India is testing PillBot, effectively doing away with the endoscopes. So there is a pill that you swallow, and they use the joystick to navigate and take photos inside. So the question is, where do you use AI and what it delivers? So with that PillBot, the endoscopes are gone. You don't need that endoscope. So that's on the surgery side. There is a hospital chain in India that uses AI for high-risk pregnancies. So they know that these are high-risk pregnancies and we need to take care of them. And so they segregate them under a specialist care. On the e-Sanjeevani that I spoke with you this morning, where we have done over 350 million consultations. So India has a unique problem. We have 36 states and union territories, and then we have almost like 1,600 dialects. So at every 10 kilometers, the language changes. It's very difficult. So what this has done is put AI. So, and in this national telemedicine platform, a doctor in one of the remote districts in southern India is talking to a patient in North India. So North Indian patient is speaking his or her language. The doctor is listening in their language. When he gives the prescription out, it is given to in the native language to the patient in North India. It's a wonderful use case of AI being used. We as Patients Union have partnered with a government program called Bhashini, which translates our entire International Patients Union app in 16 languages. You don't need to worry which language you know. So it's a classic case of use of AI. And when I look at the pharma side, right from R&D, reducing the drug discovery cycles, to logistics. Across the value chain, there is a leveraging AI for better outcomes. Even in hospitals, we have seen, because we run the courses, so we do all large-scale deployment analysis. Any patient that walked in a hospital by 9 a.m. is attended to by 10 a.m. And this has 2,000 people in the OPD per day, leveraging data and AI. So I think there are multiple use cases. Even on one of the companies I would want you to look at called Dozy. So what appears to be a skiffy, like they created smart beds. They put sensor sheets below the bed for patients. They give real vital signs to the nurses on the monitor. Nurses can see, okay, this is the patient I would need to be near to. There is a possibility of an event at this time. So they have been able to reduce code blue events. And we had recorded a lecture last week for our students on a surgery where using AI, a surgeon said very clearly, I come from a background where I don't know technology. When I start in the morning ward surgeries, I am fresh. My eyes can see a polyp. Towards afternoon, I'm fatigued doing surgeries. My eyes may skip a polyp, but my AI can spot a polyp. And even while doing surgeries, it can say, this is something that you can rupture. It's showing up in red. So I think there are phenomenal use cases of AI which are of immediate interest to surgeons, for doctors, for patients, even for providers. I mean, I think we would need a full one day to discuss of use cases.
If I can just comment on that, the number of use cases for AI are growing exponentially. And every day you'll get 30 emails telling me about a new use case or a new company. The challenge has been the evaluation of those use cases. Are they clinically useful and successful? Do they make a difference? And we saw this when we had sepsis detection. Sepsis detection was the big thing 5 years ago. It was going to solve all our hospital septicemia issues. When you did the proper evaluation, it made no difference. At the end of the day, the same number of people died, the same number of people had poor outcomes. So we need to look at AI in that respect of a proper evaluation. Same way we evaluate a drug, same way we evaluate a procedure.
And that's why I liked earlier this morning Health AI's repository of AI use cases by countries that have been properly evaluated and, if you liked, accredited as safe and doing a useful job. So just picking up on some of the things that you've just touched on. So radiology I like as a use case because so many people might not understand that we have a worldwide shortage of radiology and that the length of time it takes to train a radiologist. So actually the use of AI is significantly impacting waiting lists on people waiting for scans and getting treatment.
And that's where, Raj touched on earlier about the quality of data. So radiology data has been digital for a long time. We've had a lot of skills in making sure we get high quality digital radiology data. Subjective symptom data is really hard to digitize. So, using it where it works best. And there's a company in Australia called Harrison AI who now provides digital radiology services around the world because they start off with digital information. They can use the tools to manage that digital information. It's the old garbage in, garbage out story, which goes back to the programmers of the 1950s. If you put the wrong stuff into a computer, you'll get the wrong stuff out.
And we've already articulated for the audience the distinction between back office use cases, which is improving processes, reducing cost, and the clinical applications which we want to see to improve quality and patient service. But I'm gonna give another example. So if you came to this event in 2016, we brought McLaren, the Formula One racing team, to MWC. So you're all thinking, where's he going with this? So McLaren have the proprietary technology to the sensors in their car. So they're testing acceleration, the gearbox, braking, okay? So what McLaren have is, when they're racing anywhere in the world, the sensors are transferring data in real time to the factory in England. What most of you might not know is actually they're receiving data from every other car because it's a proprietary system. When it gets there, if you're watching on television, you might hear them say to a driver, don't use third gear, because if you use third gear, you're going to break the gearbox. How do they know this? Because the data is being used for predictive analytics, a system that they own, and they're telling the driver not to break the gearbox. It's a bit more subtle than this, because this is big data going through transfer anywhere in the world, and they switch on and off data. So anybody who's been in a hospital lately, the chances are that you heard a number of alarms going off, which the clinical staff seem to ignore all the time. So what McLaren have is that when the car is accelerating, the braking sensor is transmitting no data. And similarly, when it's accelerating, when it's braking, all the other sensors are turned off. So what they have is a predictive analytics AI model. But the really clever thing that McLaren started to do is most of the Formula One teams, in your car, you've probably got technology that was developed on the racing track. So flappy paddles on your steering wheel. But what McLaren did is they took the sensors from the car, put them into wearables, and put them onto humans and started to predict human failure. So their first clinical trial in 2016 was in a pediatrics intensive care unit. So one of the things I'd say about artificial intelligence for a second in healthcare is the innovation may come from industries outside of healthcare. So this is not just healthcare that we're talking about in this context, but lots of the technology and use cases that are being developed in other industries will be applied to healthcare. So we all need to be open to receiving those sort of ideas. And then that leads me on to the next question, which is, where's some of this innovation coming from? And do we think that it's going to be the low middle income countries that actually are the greatest source of AI innovation and development? Or do we think it could come from anywhere?
So from my view, I think today the world runs on money. So either you can save money or either you can earn money are two drivers. So mostly I see US has led the innovation, the West has led it, which it will because it needs more money. So it's more greed-based innovation. In the LMIC, it's more need-based innovation. We have less resources, we have more people to serve, people are aging, and I don't think we'll produce resources. So I think need-based innovations are going to last longer. Greed-based innovations will be subject to all the things we talked in the first session of regulation. But where I feel it's not important where it's coming from, where it's going is much more important. I mean, if you look at the past, what happened was that the pharma industry, which is one of the biggest influencers in healthcare, industrialized medicine. So if you have diabetes with the HbA1c of 7.2, they will say take glimepiride and metformin. And just imagine, after this session, when you have lunch, 6 people having the same thing, the body will break the food in a very different manner. How do you think that 6 people with diabetes with 7.2 can take the metformin and the glimepiride and have the same impact? But it serves the pharma industry very well to industrialize medicine. A medical rep will meet doctors, all patients of diabetes will get the same medication. Now what AI will do is match your phenotype, genotype, give you the medication in the portion that you need and the body works on. So I think I'm more, convinced that the real healthcare is still to come. What has happened without AI is medical fraud, which has been pushed as medicine in the name of healthcare. So where it is coming from is going to be less important, but where it's going to be more important. It's going to make us demedicalize, deindustrialize, and real healthcare. Thank you.
If I can chip in on what you just said about not about where the innovation comes, but the adoption in these lower and middle income countries, it's important also to take into consideration that, that in these countries there are not so much these legacy systems or bureaucratic inertia that for them it could be easier maybe to jump into mobile AI solutions, cloud-based solutions that it's easier for them to implement these new innovations. Obviously, taking into account that they maybe don't have the infrastructure or limited infrastructure, but from the model point of view, I think that somehow if we are able to develop more contextualized AI, taking into consideration their needs, it could be even easier for them to adopt this AI innovation than other countries. That's my perspective.
So I worked for 12 years for one of the largest technology companies in the world, and I won't name them because what I say may affect their share price. But the reality is their medical innovations were amazing. 99.9% of them failed miserably. And that's because they were driven purely from the technology aspect. What we're seeing now, and we're seeing a lot of it happening in Australia, is innovation being driven by clinicians and by consumers. So, I mean, many of you would have heard of a guy in Boston called ePatient Dave. He's now driving a new initiative called Patient-Driven AI. Their innovation is like solving the problems that they specifically have. What does a patient with cancer need to know in real time to help them alleviate their symptoms, improve their outcomes? From a clinician's perspective, we're now starting to see a huge growth in clinician-led startups. So 10 years ago, every startup that I'd met with was started by an engineer who tried to tell me as a clinician how I practice medicine. And it was wrong. And whilst Raj makes a great point around precision medicine, the promise of precision medicine and the reality still haven't met. So the fact that we can have a genotype and a phenotype and produce a digital twin sounds great, but then metformin works in 85% of people as is, so therefore, and it costs 1 cent a tablet. So how do we replace that with a multi-omic type analysis that gives us a much more expensive and potentially dangerous model? So we need to think about it. But clinicians are now looking and say, okay, here are my problems. Here is what the problem I have is I have 35 diabetics who come to see me today. 50% of them are non-compliant, but I don't know which 50%. How do I use tools like digital AI, digital health tools, to know who's not compliant and prompt them in real time? There's no use them coming to me 4 weeks later as their foot has gangrene and sort of said, yeah, doc, I wasn't compliant. If I could have used a wearable, a smartphone and a sensor in the house to just alert them, sort of saying, hey, you've opened the fridge, don't eat the sugary stuff, eat the non-sugary stuff. Those sort of things are the way we drive behaviour change. So we need to think about it from who benefits. Clinicians benefit because we've seen the burnout rates in the United States and other countries caused by the fact that they have to do so much with so little resources. But consumers, who ultimately are the people we're delivering healthcare to, by using the right tools, they become empowered to do what's right for them.
I'll just chip in on the legacy part when we said that there are legacy-based system and there are big companies. And I'll give you an example which you all will relate to. BlackBerry as a company, and you should watch this movie based on the founder, Mike Lazaris. He at one time said when Apple was launched that we have 50% market share and BlackBerry is the default phone for any professional. It was mine too. There is no BlackBerry in the world. There is no Nokia in the world. And Intel, most of you use computers, it will have that logo Intel inside. It is the biggest giant that powers all the machines. It became so big that it thought AI or no AI, we are going to be Intel. So let me give you the numbers. Q2 of 2024, they posted $1.6 billion loss. If that was not enough, third quarter they posted $16.6 billion loss. That's Intel. So no matter how big or how great you are, and I keep giving this example, you're not going to withstand this new revolution. It's going to eat you. I mean, if Intel can't survive and their outgoing CEO, which is now gone, Pat Gelsinger, has said, we are not going to be back to competition anytime soon. So I think it is upon us to forget the legacy systems. You should understand one big change. In this era of technology, there is no arbiter of information. Earlier, doctors were the arbiter of information. I had to go to George to talk about my medication, my symptoms. Like he said, metformin will be good for 85% people. What happens to 15%? Even to those 85%, we say commonly occurring side effects. What about the other side effects? Today, the democratization of information is allowing patients to decide for themselves. A dangerous sign, though, I must say, there's a warning on self-care. I have today 20 sensors inside and outside my body. I don't think I'll go to my diabetologist ever again. I know exactly my readings. I have enough information to decide what I'll do, and I think I'm managing my sugar well. It doesn't apply to most patients today. I can tell you that the future will be when a doctor will say, you do take second opinion from AI, or the patient will check and go back to the doctor. So I think if I go by examples, AI is something, whether you're legacy-based, you are big, you are great, you have a great practice, doesn't matter. AI will disrupt you right at the foundation. That's the reality we should all be prepared for. Thank you.
So I think picking up something that you've just said, George, about the need for collaborations between clinicians and technologists, one of the things that I think the ECH Alliance has seen over the last 10 years and increasingly over the last 5 years is leading hospitals creating their own accelerators, their own ecosystems of whether it's technology companies, pharma companies, AI, and actually going out and saying, here are our challenges. These are the things in our hospital that aren't working. What can this ecosystem do? So I think that I can see a time when there's going to be increasing relationships and collaborations, and also across borders, as people realize that they're facing the same challenges, and how do we effectively deal with this? So I think that for the ECH Alliance, we've got plans around how we drive best practice, how we drive collaborations between these different groups, and I think it's going to be really important in the future.
I agree. I mean, and that's really where the ECH Alliance adds that value of that global connector. Because we're doing it in Australia, you're doing it in India, you're doing it in Europe, you're doing it in Great Britain. We've seen the Africans doing it. If we can at least know what everyone's doing and collaborate on those projects, we don't have to repeat. And 90% of what we do doesn't work. If we know that up front, we don't have to repeat those things that don't work.
Yeah, it's not reinventing the wheel. So can I just turn us to something around what we think the business models might look like? So do we think that, for those people out there who are the entrepreneurs and seeing where it's going, do we think that, if you like, that the AI innovation is going to favor B2B, B2C, or B2B2C? Do we have any sort of views on how we see this evolving?
So I for sure know that the businesses will be very different. So is going to be the business case. I think the models have evolved. If you look at all the top 5 valuable companies in the world, they're all tech companies. And they are on collaboration. To your point, George, Microsoft collaborates with NVIDIA. Microsoft collaborates with Google. I think it's an age of collaborative co-creation. You cannot be competing because you kill me, I'll come with a better product, kill you. Like Kodak and Fiji, they kept fighting till Canon came with digital photography, both were dead. So I think it's a classic time, and I say it's an age of creators, not competitors. And in that case, you have to collaborate. On the business model side, I think what I'm seeing, what technology is doing is, it is taking away the middleman everywhere. Like we all watch television with our, satellite. Earlier it was the antenna, then it was the cable operators. Now it is pay on demand. There is no one in between. Same way between my books, it's Kindle and me. There is no library. So everything, what I'm seeing is a unique model is that the middleman is going away. I do not see a time when businesses will need a set of distributors, whether digital or physical, but there will be direct to consumers. And even we had a discussion in our conference last year, would DTX become what you call the consumer digital therapeutics? Will consumer buy directly? I think we all have to discuss this today, that things will move to OTC, which is over the counter. And the over the counter would be digital. So in my thought, at least I'm clear that anything that comes into between the way of users and the producers will go off. I mean, how many of you have driven self-driving cars? I mean, how many of you had a ride on that, Waymo? So I did that. Last year I was doing main stage at ATA, and the best way to demonstrate was, would I rely on the technology I'm going to talk main stage today? And I was on call with director of WHO for Digital Health and Innovation. I took a Waymo, I landed in the busy city of Phoenix without any hassles. And I had a couple of rides on the Waymo. There was no driver to talk to between the car, me and destination, it was only me. The steering moved on their own. So I think eventually I see a time when there will be no middleman between me and what I need. I'm going to just buy it.
Yeah, I think that it depends. So from my experience in the projects where we have been working on the developments that we have tried to bring to the market, it depends a lot of the use case. So there are some cases where we deal directly with a provider, so a hospital or an insurance company, and then there are more for applications for well-being or for chronic disease management, where the business is more a business-to-consumer approach, while in more complex scenarios like large-scale pilot implementations where you deal with both the hospitals or the insurers, and then they deal with the customers, is more this B2B to consumer. So I think it depends a lot on the use case that you are trying to implement.
Personally, I have some real concerns and fears around the business model. So, whilst we remove the middleman, that also means we remove the capacity to coordinate and even negotiate. So currently we use LLMs, and the companies are virtually giving us the tokens for free. They want us to get addicted to their LLMs. It's pretty much a drug dealer model. Here's the free LLM tokens. Use them now. But somewhere down the track, we're going to start charging you for those tokens. And all of a sudden, Google, X, whatever, are going to be the people who decide what access we have to those tokens. We've lost that middleman who can negotiate on our behalf. So And we saw this when we moved to cloud. When we first moved to cloud, it was nirvana. We were getting cheap computing power available to us all the time. And all of a sudden, AWS started increasing in price. Now, whenever you speak to a technology company now, their number one concern is their AWS costs, because all of a sudden their cloud costs have incrementally increased to become a major part of their cost base. So we need to make sure we don't give away the baby with the bathwater. If we give the LLMs all that power, we lose that negotiation. That may be your local doctor, that may be your local hospital. All of a sudden now Elon Musk tells us that this is how you're going to get your healthcare. That's a pretty dystopic world to look at.
So to close, a quick question to each of you. So in relation to AI and use cases and opportunities, are we optimistic and excited, or are we scared and terrified?
Optimistic but slightly scared.
As a coordinator of a European project that deals with artificial intelligence, I am very optimistic, but a little bit cautious of, to be sure that we are well grounded and the data is, we have a good data, we have a good evidence. So if we have these components and we adapt to the regulation that have been discussed during this morning and ethics concern, I think that really very optimistic.
So I think this has to have a context. So if you look at a small number of large companies, you should not be optimistic. But if you look at a large number of small companies, and I think everyone should do AI, you'll be better off, we will have more jobs. So with the right context, I'm not only optimistic, I'm sure that the future is going to be brighter and better and prosperous for everyone.
So with that, I'm going to close the panel. Thank you for the panelists. Please come back 2:15 after lunch break. Thank you.